I'd really like to thank you all for being with us today. It's an honor and great pleasure to be among esteemed colleagues. This is one of the neuro-ophthalmology lectures that is given by Dr. Alaa khamees. Inshallah, it's going to be a very interesting and rich lecture, as we always expect that from her. Today she's going to give us NMO and MOG, all of these new diseases that has been separated from optic neuritis. Dr. Alaa, you can take the floor now.
Okay, thank you, Dr. Khalil. Today, as Dr. Khalil said, we'll talk a little bit about the neuromyelitis optica spectrum disorders. We will not talk about the multiple sclerosis per se, but we will try to open our minds to schedule when we should think about these spectrum diseases, including NMO, MOG, and the third entity, neuromyelitis optica spectrum disorders like atypical multiple sclerosis and these diseases. So we will start with a case. A 38-year-old female patient presented to us with a history of multiple sclerosis, presenting with sudden onset painless right eye visual field defect. Her past medical history included episodes of difficulty walking. The left eye vision was lost at the age of 35, leading to an initial diagnosis of multiple sclerosis based on brain plaques seen on MRI somewhere else. The visual acuity at presentation was 20/50 in the right eye and chronic hand motion vision in the left eye. The left eye had a significant relative afferent pupillary defect, diminished color perception in the right eye, optic nerve pallor in the left eye. Visual field testing was not possible for the left eye, and a progressive secocentral scotomas noticed in the right eye. So when we have a patient with these symptoms and signs, at first we will think about the history of the patient: autoimmune myelitis, including multiple sclerosis, optic neuromyelitis, lupus, Sjogren sarcoidosis, and among others. There's inflammatory causes. We should think about infectious myelitis and other rare causes like spinal and CNS lymphomas. This patient was referred to the neurologist to do the rest of the investigations, and the key positive lab finding in this patient was an elevated aquaporin 4 IgG antibody, also known as NMO IgG. And that led to the diagnosis of neuromyelitis optica rather than her previous diagnosis of multiple sclerosis. So as we said, we will talk today about how to differentiate when we should think about these disorders rather than multiple sclerosis, because that can affect the management and the prognosis and the follow-up of the patients dramatically. The NMO-ST diseases, they are multifocal CNS demyelinating diseases that primarily affect the optic nerve and the spinal cord. Historically, NMO was known as Devich's disease, named after Fernand Devich, who published a case report in 1894 of a patient with simultaneous bilateral optic neuritis and myelitis. Until 2004, NMO and NMO-ST were often considered a subset of variant of multiple sclerosis, until Lennon and his colleagues identified the NMO antibody, as we said, aquaporin 4 IgG, proving it was a distinct pathophysiological disease rather than a subtype of multiple sclerosis. The pathophysiology, as said, the pathogenetic mechanism is about the aquaporin 4 antibody, which is directed against a protein, the water channel protein, at the terminal of the astrocyte processes. This causes a blockage of the water channel and subsequently intracellular edema. This leads to secondary inflammatory reaction in which interleukin-6, plasma cells, but also T cells mediated reactions play a role, resulting in structural damage to the astrocytes and blockage of the nerve conduction. Epidemiologically, NMO and NMOSD are rare, 1 to 100 patient ratio to multiple sclerosis. But the incidence of these diseases is increasing, which is probably due to the fact that NMO is more frequently diagnosed nowadays by the detection of aquaporin 4 antibody, whereas in the past it was classified as an atypical multiple sclerosis and was not recognized as separate disease. Women are affected more often than men. Disease is more common in Asia. The age of onset is typically middle adulthood, 30 to 40, but there is a wide age range between 10 and 90 years of age. There were cases of NMO were diagnosed at this age spectrum. There's now a diagnostic criteria from 2015, international consensus criteria, and NMO disease is now under the grosser entity of the Neuromyelitis Optica spectrum diseases. For patients of positive or elevated aquaporin 4 IgG, diagnosis requires at least one of the following core clinical criteria: optic neuritis, acute myelitis, characteristic brainstem syndrome. We will talk a little bit about these syndromes like area postrema syndrome, acute diencephalic syndrome when it involves the hypothalamus and the thalamus, and cerebral syndrome. The last two criteria, diencephalic and the cerebral syndrome, should also have MRI findings supporting the diagnosis. For patients without positive aquaporin 4 IgG, that means some patients with NMO diseases have negative aquaporin 4 IgG. More clinical criteria and additional MRI findings are needed for the diagnosis. Some information about this area postrema syndrome. This typical appearance, as you see here at the medulla, the surface of the medulla oblongata, you can see a V-shaped circumventricular demyelinating zone. Radiologically, it can be identified. It is hypointense in T1, hyperintense in T2. On midgladianum stain, the enhancement is variable. Diencephalic syndrome, that's when the demyelinating lesions involve the thalamus or the hypothalamus. The patient can present with symptoms like severe sleepiness, narcolepsy, appetite weight issues, failure to thrive in children, emaciation in elderly, unusual eye movement, SIEDH, and this syndrome often requires urgent immunosuppressive therapy. So when we have a patient with optic neuritis and we are suspecting this autoimmune spectrum disorders in NMOSD, we must now ask about these symptoms. We must ask in area postrema syndrome. We'll talk about it a little bit. It involves retractable hiccups, unexplained vomiting and nausea. We should ask the patient about these symptoms before referring them to the neurologist. Cerebral syndrome, when the brain inflammatory changes at the cerebral cortex, that cause symptoms like confusions, seizures. Sometimes the patient can present with encephalopathy. Now, how we should, or when we should think about the NMOSD syndromes, or is it merely an MS, multiple sclerosis? In multiple sclerosis, we all know the Dawson fingers, this typical hyperintensities perpendicular to the lateral ventricle. Here you see the whitish spots, like the fingers protruding from the surface of the lateral ventricle. They are typical for multiple sclerosis. For NMO, the distal spinal demyelination foci involving more than 3 segments, there are suspicious for neuromyelitis optica disease. Okay, in NMOSD, the lesions, the demyelinating lesions have usually a cloud-like pattern that's specific for them. But despite these differences, as we said, the radiologist or the neuroradiologist can say in 70 to 80% of the cases, okay, these findings are typical for MS or NMOSD spectrum diseases, but over 15% of NMOSD patients still meet the MRI criteria for MS. That means they may have Dawson fingers or non-cloudy demyelinating lesions or smaller size of the demyelinating lesion in the spinal cord. The prevalence in MOSD is much rarer. We said 1 to 100. The initial course, both often present initially with a relapsing remitting course. Both can have at the beginning monophasic presentation. 15% of NMOSD patients present monophysically, one CNS attack with complete recovery, and then they will have a remission for a period of time, and then the other symptomatics can occur later. As we said, less common manifestation, these are bulbar symptomatologies, or as we said earlier, posterema syndrome, refractile hiccups, nausea, or sometimes caudal cranial nerve symptomatology can present in patients with NMO. In contrast to MS, that's important to remember, there are no cerebellar disorders, no cerebellar signs or MRI involvement in patient with NMO. If you have the cerebellar signs or symptoms, you must consider other diagnoses rather than the NMO. The CSF findings, the NMOSD patients tend to have more white blood cells and pleocytosis, while MS patients often have oligoclonal bands. Associated condition in NMOSD is commonly seen with other systemic autoimmune diseases. Bilateral optic neuritis, as we said, that was the initial discovery for the NMO diseases, bilateral optic neuritis. Visual recovery is often worse for NMOSD patients. A study showed that 50% of NMOSD patients had worse vision than 0.1, 20 to 200. Vision 5 years after the initial optic neuritis episodes, compared to 4% in an MS optic nerve, in the MS optic nerve treatment trial. Testing for the aquaporine 4 IgG antibody, we always leave that part for the neurologist, but we will talk a little bit about the testing. Only 3 to 5% of patients with single optic neuritis episodes and no other neurological history are positive for aquaporine 4 IgG. That's why we do not test all the patients with initial attack of optic neuritis for IgG4. We will talk a little bit about when to test for the aquaporine 4 IgG antibody. The detection in serum is pathognomonic as well as highly specific and thus conclusive for the NMO. However, these are initially only found in about 50% of patients, only in the course of time at up to 90%. Initially highly specific but not sensitive. A lack of detection of aquaporine 4 antibody, this K was in German, its antibody, does not rule out the disease. So when to consider testing the patient who have optic neuritis plus an acute brainstem syndrome, bilateral visual symptoms, recurrent optic neuritis or poor visual outcomes, and concurrent autoimmune disease. Lumbar puncture, as we say, there is more white blood cells, more pleocytosis in the NMO patient, oligoclonal band in the multiple sclerosis patients. In electrophysiology, as we said, the presentation, the symptomatology is always worse in the NMO patient. That's why in the visual evoked potential, the latency prolongation and amplitude reduction can be seen. In the presence of myelitis, the motor evoked and sensory evoked potential from the extremities may be delayed or sometimes absent. Now, we talked about the NMO. So now we will talk about these spectrum diseases. While the discovery of aquaporine 4 antibody initially led to the diagnosis of NMO, we have the new nomenclature that the NMO-ST diseases. These include incomplete courses of NMO, such as isolated longitudinal extensive transverse myelitis without other symptomatology, and recurrent bilateral optic neuritis without spinal symptoms. They are not in the NMO-ST criteria, and they are not in the typical multiple sclerosis criteria. Now, we will talk about the MOGAD syndrome, MOG antibody disease versus the neuromyelitis optica spectrum disorder. NMO-ST usually, as we said, involves antibodies against the aquaporin 4, while the MOGAD involves antibodies against the myelin oligodendrocytes glycoproteins attacking the myelin. MOGAD often has better recovery despite more severe attacks, while aquaporin 4 NMO diseases has higher risk of disability accumulation. MOGAD patients often being younger males with optic neuritis, while NMO-ST patients are typically females with more myelitis symptoms, with NMO-ST patients needing more intensive therapy like rituximab or plasma exchange. The treatment evidence is usually from retrospective studies. First-line treatment for the acute attack, as in cases of acute multiple sclerosis attack, high-dose IV methylprednisolone for 5 days with an oral steroid taper. Sometimes we need chronic immunosuppressive therapy. This is crucial because certain medication used for MS can worsen or inadequately prevent the relapse in MOST patient. These include natalizumab, interferon beta, and glatiramar. Best therapy, according to the respective studies, now are rituximab and azathioprine. What for recurrence prophylaxis? The data is still unclear due to the rarity of these diseases. First of all, it's important to know that the basing therapeutics used for prophylaxis in MS seems to worsen the NMO and are therefore contraindicated. That's why we need to distinguish these disease entities, preferably from the beginning. The prognosis, as said, little is known because of the rarity of the diseases, but with the time we know more and more. NMO usually is a chronic recurrent disease, and relapsing occurrence of symptoms is typical in these patients. In some cases, however, the disease activity comes to a still stand or stability again after a single relapse. As we said, they can be monophasic. Severe courses of the disease and defective conditions with persistent visual impairment and paraplegia symptoms occur in these disease entities more often and more frequently than in multiple sclerosis. Thank you.
Thank you so much, دكتورة. فعلا جميل جدا. I have like a few questions, if you don't mind. You mentioned that NMO-SD affects astrocytes. So these astrocytes are actually found at the head of the optic nerve. So patients with papillitis are more likely to have atypical optic neuritis.
Actually, I didn't read it. I don't know, but actually they present more often with retropalpar neuritis, such as the patient of multiple sclerosis, 90% retropalpar and 10% papillitis. So I don't know exactly of if there are any studies are supporting this hypothesis. I don't know.
Okay. Another question: the link between the optic nerve and the brainstem. Do you have any logical link that tells us that why the patient has the brainstem problems along with the optic nerve problems?
The problems are usually at the aquaporin channels. So where you have more aquaporin channels, there is more involvement of the disease in the NMO patients. That's why they have myelitis very often. And that's why the foci, the demyelinating foci, usually larger, because they are usually the adjacent channel are all inflamed, not a foci of autoimmune inflammation. So why, especially in these areas, it has to do with the presence of channels. There is a lot of things that we cannot explain now. I asked sometimes, or a few years ago, why we have these Dawson fingers in multiple sclerosis patients. So, for example, then came the explanation: they are adjacent to the blood vessels. They are very, very frequent and very. They stay very, very adjacent to einander around the ventricles. That's why we see the inflammatory foci. But there are blood vessels everywhere in the brain. Why we have these inflammatory foci in this lesion and not the other lesions? We have a lot to do. That's the rule of research and studies, but it is, as we said, it's the aquaporine cells where you aquaporine channels where you have more of these channels, and typically that's in the where the brainstem, around the ventricles, but also where the cerebral cortex is. We have the cerebral syndrome. So we don't know everything about these disease entities, but that's what the talk about. That's what the scientists hypothesizing, thinking about.
Any other questions from the colleagues?
الله يعطيك العافية دكتور آلاء. دكتور خليل الله يحفظك الله يسلمك. أنا هيك بس تعليق، أنا متفق معك إنه الآن يعني طلع هيك نيو كلاسيفيكيشن خلينا نحكي للأوبتيك نيورايتس أو الأوبتيك نيوروباثيز. أوكي، فيمكن من الأشياء اللي بهيك يعني كلياتنا نتذكرها إنه you have to refer your patient to a neurologist حتى يعني could help in definitely in the treatment. بس السؤال يعني يعني let's say what type of cases you will go directly to ask for the aquaporine for antibodies, IgG antibodies test?
Yeah, exactly. The cases, as we said, bilateral involvement, severe involvement.
Simultaneous,
or in short period from each other within 3 months. They talk about the 3 months period. So very narrow on each other, the symptomatology, bilateral severe involvement. We know typically the multiple sclerosis patient, they have mild reduction in visual acuity or not hand motion or counting fingers. So the lower the visual acuity, the more possible that the patient has these NMOSD spectrum. Associated autoimmune diseases, Sjogren's syndrome, SLE, as we said, they come more often with the NMOSD spectrum. So we must do now aquaporine 4, and now we are investigating for MOG. For MOG antibody. So, as we said, bilateral and spinal involvement, severe spinal involvement, we have to investigate for NMO. As we said, in diencephalic syndrome and area posterema, retractable hiccup, severe nausea and vomiting, narcolepsy, these symptoms, these typical symptoms, I must ask for these antibodies. And the other side, when we have cerebellar functions, cerebellar impairment, we usually don't think about the NMOSD spectrum. We think it's maybe only multiple sclerosis or atypical multiple sclerosis.
So my let's say question, do you advise to treat each patient with optic neuritis, even let's say solitary, unilateral optic neuritis without any other symptoms, to prevent, let's say, the contralateral involvement within a few months or within a few weeks؟ بالعادة كنا زمان
بريدنيزولون IV مثال بريدنيزولون.
I mean احنا بنعرف انه السيناريو كان للاوبتيك نيورايتس إنه with or without treatment vision will recur to almost 6/9 or with or without steroid treatment. هذا كان الكلاسيكال teaching مظبوط؟
Yes.
فإنه يعني الend result صح it will يعني hasten or fasten the recovery. لكن بالعادة بالعادة الend result should be the same.
Yes.
Does this, let's say, or is there any difference between the, let's say, the neuromyelitis optica syndrome spectrum and multiple sclerosis? I mean, do you still advise to treat each patient? لأنه إحنا first attack يعني كثير بتشوف young patient with first attack optic neuritis وتستنى عليه شوي. طبعا في ناس بيكون شايفه قبليك ومش يعني صار لها مثلا few weeks. So do you still advise to treat the patient with methyl and let's say oral, followed by oral for each patient with suspected optic neuritis, whatever, let's say underlying or differential تبعه؟
هلا دكتور ال IV methylprednisolone doesn't have anything to do with prophylaxis, so it will not affect the involvement of the other eye. So we are treating only, or we are enhancing the speed of the recovery of this inflamed nerve, of this acute optic neuritis attack. So when the patient comes few weeks after his symptomatology or his optic neuritis attack, usually we refer to the neurology to make to make the full examination, because the neurologists, they have their criteria for treating very large enhancing lesions in MRI, multiple lesions separated in time and location, so they can treat regardless of our optic neuritis diagnosis. So we refer always to the neurology. IV methylprednisolone only as fast as possible after the acute attack to speed recovery, because as you said, the treatment will not affect the prognosis later on with IV methylprednisolone. The immunological treatment, it affects we have now a large spectrum of therapies that affects the prognosis and makes the life of these patients, of all the groups, NMOSD, multiple sclerosis, it makes their life better. But there is usually our MS patient and our NMOSD patient, they are usually young and they need something. They need to be treated. So I know it's not to, I tell the patient it's to enhance the prognosis, but we need to follow up with a neurologist because there are therapies that can stop or slow the progression. So they need therapy, yes.
Yeah. بس حتى IV يعني إذا أعطيت أنت IV followed by oral, بديش أحكي it's not a prophylaxis, but the recurrent attack, it will be less frequent, مزبوط؟
multiple sclerosis, but yes, it's not, that's not, don't apply to the NMO patients.
I know, but do we have the same recurrent attacks in this spectrum? Let's say, do we expect a patient could have first attack of optic neuritis, then after a year or two may have another attack?
Yes. They 15% of them, they have monophasic attack, few years of silence, then the more profound attacks can follow. Yes. But the prophylaxis, as we said, it's with the immunological therapy, and some immunological therapy that we use for the multiple sclerosis is contraindicated in the NMO patients. That's why we have to work in a team with a neurologist in these spectrum diseases.
اوكي، الله يعطيك العافيه.
يعافيك يا دكتور.
الله يحفظك.
الدكتورة، اذا بتسمحوا لي سؤال.
تفضل دكتور.
انا بداوم مثلا بمستشفى